This first case Articles on the Go feature is titled 4 Misconceptions About Surgery Turnover Time, written by Paul Wafer, BS, MBA, RN. The incentives to be efficient in the operating room have never been greater than today. The changes in reimbursement from the Accountable Care Act are creating new alignments between physicians and hospitals that will require synchronous workflows to maximize the potential to provide high-quality outcomes at an affordable cost. By keeping costs reasonable, both the physician and the hospital will be able to sustain profitability in an ever more challenging environment. The time it takes to remove one patient from the operating room and put the next patient into the room, turnover time, is frequently used as a benchmark to determine how efficient a department is working. While turnover time can provide some measure of efficiency, it's important not to rely on this number alone to determine how well your surgery department is running. In our consulting practice, we've seen several examples of hospitals with average or better than average turnover times with tremendous inefficiencies. Some examples of other factors that can influence the efficiency are as follows. 1. Bringing the patient into the room too soon. A very busy urban hospital with 11 operating rooms brought us in because they were getting a lot of complaints from their physicians about it taking too long between cases. The surgery data showed that the time between patients was actually better than the average hospital. Upon further analysis of the data and through observation, we determined that the staff were bringing the patients into the operating room before the team had opened supplies and ensured that all supplies and equipment necessary for the case had been picked properly. When we looked at the time from the patient entering the room until incision, these stats were extended far beyond the average time. Not only were the physicians dissatisfied with the situation, the patients were exposed to a lot of inappropriate conversation among the staff members who were setting up the room. 2. Differences in case mix. The acuity and complexity of surgical procedures can also have a major impact on the turnover time between cases. Certainly, procedures with multiple trays of instruments and/or complex pieces of other equipment, like total joint procedures, spine cases, and robotics, can have a major impact on the time it takes to prepare a room for a patient. Conversely, minor procedures like excisions of lesions, cataract extractions, and minor gynecological procedures may have very quick turnovers. An example of this is a hospital that had an outstanding spine surgery program. We expected to see extremely long turnover times, and were surprised to find they were better than average. Upon closer examination, we found that this facility was also performing epidural blocks for back pain in high volume in their operating rooms. These quick cases brought down the overall average. By excluding the epidurals from the total, the true average was more apparent. This very efficient operating room still had exceptional times. 3. Switching rooms will always save time. The theory behind this is simple. If you don't have to wait for the room to be cleaned up, you can get the next case started faster. The truth is that, under the right circumstances, switching rooms can be extremely efficient. At other times, it can create a great waste of resources. I'll discuss this in detail in a future article, but the key factors to consider are as follows. Is there a separate nursing team and anesthesia provider available for the other room? Is there special equipment required for the procedure, and are there duplicates available? Is there an assistant that can close on one case while the surgeon drops out to start the next? How long is each procedure? What is the setup time and cleanup time for the procedure? All of these factors can influence the decision to switch or flip-flop rooms between cases. 4. More people are needed to improve turnover time. Frequently, the response you will receive when asking what is needed to improve turnover time is that the department needs an additional housekeeper or nursing assistant to help get things done quickly. This may indeed be the reason for delays, but it's important to understand that the cause of delays starts as early as when the procedure is scheduled in the physician's office. There are literally dozens of variables that can impact the ability to get a case started on time. Throwing additional personnel at the problem will not work if other processes and barriers are not addressed first. Most of these variables can be put into one of 3 categories: hospital operations, patient compliance, or clinician compliance. These variables must be thoroughly vetted before deciding on the addition of more personnel. In this article, we have only addressed the room turnover time as an indicator of efficiency. We always recommend looking at a number of other time variables as well, such as the time from surgery end or closure on one case to surgery start or incision on the next case. This is really the surgeon's perception of turnover time and a better measure of efficiency from the surgeon's perspective. You should also look at the time from surgery end or closure to patient out, or how long it takes to get the patient out of the room after the surgeon finishes. If this time is extended, it could indicate a number of potential issues, from a backup in the PACU, inefficient anesthesia providers, or lack of personnel to move the patient, just to name a few. In other words, to ensure the most efficient use of your perioperative service, you should be monitoring several time variables and be able to interpret what could be impacting the results. As always, thanks for listening to this episode of First Case Articles on the Go.